Good morning, everyone.
Good morning, Greg.
I want to thank Rev Tim for allowing me to speak with you this morning. When I say allowing, I mean strongly encouraging, browbeating. We rightfully consider ourselves to be a congregation that is dedicated to loving kindness and one that wants to be the change that we want to see in the world. But it's hard to be that change if you don't know what needs to be changed. I was talking with Chris Little the other day about the long range plan, and he said that a GPS can't tell you how to get to where you want to go unless it knows where you are. To that end, I'm going to shed a little light on where we are. A while back, I stood up here and talked about the ocean of privilege and the river of racism and how I need to focus my attention as a healthcare provider on addressing those issues. This morning, I want to invite you to join me in swimming upstream, swimming against the tide. I'm going to talk about health equity, defined by the CDC as the state in which everyone has a fair and just opportunity to attain their highest level of health. I'm going to focus on equity as it relates to race and ethnicity, but it is crucial to keep in mind that there are health equity issues related to many social, economic, demographic, and geographic dimensions such as age, sex, gender, sexual orientation, disability, and that often these dimensions intersect with multiplicative rather than additive effects. I'm going to start with a story which comes from our younger son, Damon, with whom I share with my lovely wife, Pam, who is a resident in plastic surgery. Damon often takes call from the pediatric emergency room and always insists that if he is going to need to perform a procedure on a child under the age of 12, that child needs to be sedated. He noticed over the course of several months that he would often get some resistance from the emergency room docs when he asked them to sedate a child, but that they would more readily relent if the child were white versus Black or Latinx. It all culminated recently when he was called in to perform a procedure on a 7-year-old child. When Damon asked the emergency room to sedate the child, they declined, saying that the child didn't need it because he was stoic. When Damon arrived, he found this child wasn't stoic, he was in shock. When he again asked ER docs to sedate the child, they refused. With the help of the child's attentive and loving mother, Damon was able to anesthetize the child's hand, but not without some difficulty. I mentioned that the child was Black. Appalled at his experience, Damon then researched whether this was a pattern in this emergency room and found that Black children were 60% less likely to receive sedation for the same problems and procedures than were white children. This is not an isolated phenomenon. This is a pattern that has been documented in scores of research articles from around the country, demonstrating that Black and Latinx and Native American patients receive inferior care compared to the white patients. But the problem goes much deeper than the health care that people receive. It is an issue of the long-lasting and far-reaching legacy of racism in this country and its impact on the health of people of color. Now, I promised Rev Tim I wouldn't show too many graphs or charts, which is my usual style, but I want to share a couple with you. Rachel, can you show the first slide? So this is a map of the census districts in Charlottesville, and you can see next to each other, these two census districts have a difference in life expectancy of 9 years. And you can see, I don't know if you probably may not be able to read these, but these are the charts of the breakdown by race on these two census districts. And basically, this district has about 8% Black and Latinx individuals, and this one has 48%. Rachel, next slide. In case you folks in the county are feeling smug, so this is a map of the census districts in the county. We've got one district here that 87-year life expectancy. This one here is a 77-year life expectancy. 0% Black individuals here, 8% there. This again plays out across the country. Among the 500 largest US cities, 56 have life expectancy gaps between census tracts of at least 20 years and some over 30. The largest life expectancy gaps occur most frequently in cities that have the highest levels of racial and ethnic segregation, which is to a great extent a residual of federally implemented neighborhood redlining. Now, we have known for decades that significant differences in health related to race and ethnicity exist across just about every health domain that you can think of, and that people of color receive fewer interventions than do white patients in just about every health domain that you can think of. And people are constantly scratching their heads about why this is. Rachel, next slide, please. This is why it is. It's racism. But that begs the question, why is this racism? Rachel, next slide, please. Now, I am not going to unpack this slide in the next 5 minutes. I know it's a complicated, busy slide, which is the point. The point is that racism touches everything that we can do in regards to a person's health across the lifespan, across institutional levels. Generally speaking, health inequities are caused by multi-level systemic mechanisms that distribute power and resources differently across lines of race, gender, class, sexual orientation, gender expression, and other dimensions of individual and group identity. This unequal and unjust allocation of power and resources rears its head in unequal social, economic, and environmental conditions, the social determinants of health. I ran across a quote several years ago by the Reverend Martin Luther King Jr., and it read, "Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane." Now, coming from Dr. King, that is an extraordinarily powerful statement, considering that he had heard about, witnessed, and experienced more than his share of inequality. But I learned recently that the quote, as I learned it, is both inaccurate and incomplete. What King actually said in 1966 to the Medical Committee on Human Rights was, "Of all the forms of inequality, injustice in health, not healthcare, is the most shocking and the most inhuman, not inhumane, because it often results in physical death." Now, why does that matter? Because healthcare, in the quote as I first heard it, is a comment on how people interact with the healthcare system, whereas health, from the actual quote, is a reflection of how all of society impacts a person's well-being. Because inhumane, from the incorrect quote, suggests a lack of compassion for human suffering, whereas inhuman suggests a condition that is so cruel that it is not suitable for humans and inhospitable for human life. And because it is important that Dr. King recognized that the consequence of injustice in health is the ultimate consequence, which is to say death. Earlier, Rev. Tim and I read excerpts from Maya Angelou's compelling poem, Equality. I want to say a few words about the concepts of equality and equity. Rachel, next slide. Now, some of you may have seen this graphic representation of equality and equity, making the point that whereas equality means giving everyone the same resources, equity means giving everyone what they need to succeed. And while I appreciate the effort to make this distinction in an easily understandable way, I always had a problem with this graphic because it suggests that the sole reason that some people are disadvantaged is because of something inherent in them, which may be true in some cases. I prefer something like this, Rachel. This makes the point that even when people are seemingly equal, they may not have equal opportunities because of the way that society treats them, which is why equity and justice are so important. It is estimated that between 1999 and 2020, Black Americans experienced more than 1.6 million excess deaths compared to white Americans, representing more than 80 million years of life lost. COVID made this even worse. COVID shone a glaring spotlight on health inequities related to race and ethnicity in this country. It is also estimated that racial health inequities cost the U.S. more than $400 billion in 1 year, 2018. And that number is estimated that it may balloon to $1 trillion by 2040. This is a public health emergency that affects us all. And that's where we come in as individuals and as a congregation, because we can be the change we want to see in the world if we choose to recognize where we are, where we want to be, and what we need to do to get from here to there. It would be natural to think that this problem is too large for us to be able to impact it. Well, we don't have to start with fixing a $1 trillion problem. We can all learn about implicit bias and how to fight it in ourselves and in our society. We can begin to or continue to educate ourselves on where the problems lie in our spheres of influence as individuals or as a congregation. Then we can look around and see what we can do for one person, for one household, for one neighborhood, for one school, for one community. We can commit to helping marginalized individuals get the care they need, driving them to healthcare appointments or the pharmacy. We can think about how we can contribute to addressing issues of home improvement, transportation, community health programs, housing supports, resource assistance, and other services that address the social determinants of health. If you're in education, you can work on ways to guarantee access to high-quality early childhood education, support disciplinary policies that minimize expulsions, promote opportunities to keep high-risk kids in school, help them graduate, and support LGBTQ+ needs in schools. If you're an employer, you can support paid family leave, promote healthy behaviors among your employees, offer training on implicit bias, commit to improve the hiring and retention of workers with disabilities. If you work in housing or development, you can include community members in decision-making. You can support zoning regulations that encourage high-density, inclusionary, transit-oriented development. You can learn about how structural barriers produce segregated neighborhoods. Those of us in healthcare can adopt new vital signs to screen for the non-medical factors influencing healthcare, like access to food and potential intimate partner violence. Guard against the potential for bias to influence our medical care, and make sure elderly, women, and racial and ethnic minorities are adequately represented in clinical trials. Understand the effects of adverse childhood experiences and use trauma-informed care. If you like communicating with your elected representatives, and I know some of you do, write to them about making sure your local government has removed questions about convictions from job applications, about ensuring that non-English speakers can access social services, about increasing minimum wages to the level of a livable wage. We all have skin in this game. I invite you to fully participate in making our communities ones in which, as the CDC says, everyone has a fair and just opportunity to attain their highest level of health. Albert Einstein, he knew a little bit about some things. He said, "Those who have the privilege to know have the duty to act." Now you know. Come on in. The water, it's not fine. It's not fine. Not yet. But we can be the ones to make it so. Thank you.